Monday.
Yes, good afternoon, good morning, colleagues. Thank you once again for joining. I'll be handing over to Dr. Idowu Lateef, who is going to walk us through the epidemiological situation across the globe and across Africa. So over to you, Dr. Idowu Lateef, for the EPI update for today.
Thank you very much, Dr. Yewande, and good morning, good afternoon, good day to everyone wherever you are. Welcome to the week 2 of our series 3 of infection prevention control webinar. So globally, the epidemiological situation of COVID-19 as of 9 a.m. East African time today shows the map of the world with dark blue color shows the country, areas, and territories that are reporting more than 100,000 cases. And the very light one shows the countries reporting between 1 to 1,000 confirmed COVID-19 cases across the world. On the right shows the epic curve of a number of new COVID-19 cases reported by day on the x-axis. And the green color represent the PAL region, which happened to be the epicenter across the world. Overall, we have more than 21 million confirmed cases, which have resulted in over 770,000 deaths, with case fatality rate of 3.5%. This slide shows the trend of COVID-19 cases in Africa, and the two epic curve shows the number of new COVID-19 cases by day across the continent, with the upper epic curve shows across the 55 member states, and the average percentage increase in the last week was 7%, with Eastern Africa region having the highest of 14% and Central having the lowest of 3%. The lower epic curve shows the COVID-19 cases across the continent without South Africa. As you are aware, South Africa is the epicenter in Africa. So without South Africa, the average percentage increase for the last week was 9%, with Southern Africa region having 18% and Central having the lowest of 3%. Overall, we have more than 1.1 million cases across the continent, which have resulted in over 26,000 deaths, with case fatality rate of 2.3%. The good news is 76% of these total cases have recovered. This table shows the distribution of COVID-19 new cases, death, and recoveries by region. In the last 24 hours, we've reported 7,827 new cases, which have resulted in 394 deaths, and the new recoveries happen to be more than 11,000, with case fatality rate of 2.3%. And the Southern African region reported the highest number of new cases of 2,861, with 295 deaths, and recoveries of 8,611. This slide shows the map of Africa with 33 countries reporting less than 5,000 cases, 9 countries reporting between 5,000 to 10,000 cases, 1 country reporting more than 100,000 cases. Compared to last week, we can see that we have 2 more countries that have moved from less than 5,000 cases to between 5,000 to 10,000 cases. And that is so we move to the next slide, which shows the new COVID-19 cases and deaths by region. And the total number of new deaths happens to be 2,340, with new cases being 71,070, and the case fatality rate of 3.3%. This is my last slide, shows the newly published infection prevention and control guidelines, which are available on the Africa CDC website, along with other guidance and resources that have been produced by Africa CDC. The first is guidance on setting up an isolation ward for COVID-19 cases. And the second one is guidance on infection prevention among contact tracers in Africa. Thank you.
Fantastic. Thank you so much, Dr. Idowu, for walking us through the epidemiological situation across the globe and in Africa. It's good to see that despite the increased number of cases, our recovery rates are starting to look up. And that's why we're really doing this, to ensure that we limit the transmission and control the transmission of SARS-CoV-2 across our continent. Our next presenter will be Professor Andrew. If you could share your slides, and the floor is yours for your teaching session.
Hi, thanks very much. Can you see my, I don't know why it's not doing this properly now. Okay. Sorry, let's try and share again. Oh, there we go. Okay. So hopefully you can all see my screen. And thank you very much to the organizers for inviting me to present today. And good morning or good afternoon to everyone, depending on which time zone you are sitting in. So I'm a medical microbiologist, not a virologist, and you may wonder why I'm going to be talking about COVID, being a non-virologist, but we've had quite a lot of discussion in our Department of Pathology around laboratory safety, and I was involved in certainly some of the safety guidelines which wrote for our department and contributed to for the National Health Laboratory Service. So I'm going to kick on focusing on biosafety in laboratory settings with a particular reference on COVID, but maybe some general principles as well. Okay, so I think everyone's aware of this, but it's worth highlighting just some of the key points around the transmission of SARS-CoV-2. And the bulk of transmission is really happening in the household, and obviously there's a coding of transmission with transmission from infected patients to healthcare workers. And there's been quite a lot of debate recently, people are aware of, around the predominant mode of transmission. Certainly for a long time it was really, the focus was on respiratory droplets and contamination of fomites, as well as direct transmission of droplets to mucosal surfaces. But it seems clear that aerosol spread and an airborne component does exist for SARS-CoV-2. I think there's still lack of clarity as to what contribution airborne spread makes compared to the sort of larger respiratory droplets. And for a while, our focus on airborne and aerosol spread was around ICU settings and in individuals where aerosol generating procedures were being done. What's probably more important, certainly I think from our perspective and the perspective of laboratory workers, is that, and the general population, is that people are infectious before the symptoms onset, symptoms develop, and for a few days after recovery. And there's also likely to be a substantial proportion of asymptomatic infections occurring. So, and even asymptomatic individuals are believed to be potentially infectious. And I think all this talks, if you look at the little cartoon on the right-hand side here, which illustrates the sort of timelines in general principles, is your infectious period is probably around about 8 to 10 days of the illness, but you can be infectious prior to developing symptoms as well as while you are symptomatic. Okay, so I'll come back to this point just now, but let's talk briefly about what laboratories do in managing and controlling the COVID epidemic. And obviously, when you talk about the laboratory's role in COVID, the first thought is around diagnosis of the condition itself. So that's generally done in virology laboratories or combined virology microbiology laboratories. And that's generally, at the moment, PCR assays to detect the virus in respiratory specimens. And that's how we diagnose if somebody's having COVID-19. There's also a role for epidemiological surveillance, also using PCR tests. This is not yet widely practiced, but certainly there's a discussion around using environmental reservoirs, such as sewage, to track transmission and burden of disease in different geographic regions, and possibly to use as an early warning system. Also done in virology laboratories. Quite a lot of laboratory work will revolve around non-virological samples, but for patients who are admitted with COVID-19, where you need assessment of severity of illness or assays to look at prognosis and outcome and so on. And this will be from hematology to chemistry to microbiology to even to histopathology. So looking at white cell counts and CRPs and MCNS on respiratory samples and so on. So there's scope for a large number of samples from patients with COVID-19 to come to the laboratory, and many of them are not necessarily for diagnosis of COVID-19, they're there for evaluation of the patient's severity and prognosis. And then finally, the last role of the laboratory, which is also, I think, something that's evolving as we speak, is the use of serological testing to not so much diagnose COVID, but for epidemiological surveillance, to look at how many people may have been infected in the population, regardless of whether they're symptomatic or not, and to understand the burden of disease and, I suppose, incidence and prevalence rates in particular populations. And obviously very important for vaccine studies as well, to look at immune responses to potential vaccines. So the laboratory has as with all infectious diseases, the laboratory's got quite a wide scope of roles. And when we talk about laboratory safety in the spectrum of COVID, I think it's important to remember that it's not only the virology laboratories that are important. It's any diagnostic laboratory is going to be exposed to potentially infectious specimens and needs to be aware of that. When COVID first started in our laboratories, there was a lot of concern amongst laboratory workers around their risk as laboratory workers of contracting COVID as a result of working with theoretically highly infectious samples. What is, I think, clear, certainly from experience with previous coronaviruses and our experience now, is that there are a number of ways in which a laboratory worker may become infected with SARS-CoV-2. And if you look at the cartoon on the left, probably the commonest way is actually through the normal transmission mechanisms that apply to everyone in the community. So it's infection through, it's coming into contact with an infected individual, and you then become infected through either droplets or possibly aerosols, and direct and indirect contact with contaminated surfaces. And for anyone working in the laboratory, that is most likely where you're going to become infected. Some laboratory workers are involved in specimen collection, and that is a potentially high risk exposure. You are shoving a swab up someone's nose or down their throat. You are very often making them cough and splutter when you do that, and that is going to expose you to close contact with respiratory secretions. So if laboratory workers are involved in specimen collection, that would be one area where their work exposes them to high risk. And then the other potential risk in the laboratory is both working with the specimens themselves, and this is an old picture before we all had to wear masks, but just showing laboratory workers working together with clinical specimens, but also working in close proximity to other people. So, and I think it links up to the cartoon on the left, that laboratory workers are probably far more likely to contract COVID as a result of their exposure to their colleagues in the workplace, as opposed to their exposure to the specimens themselves. And I think that it's important to bear this in mind when we talk about safety in the workplace. While it's important to make sure that you handle the specimen safely, it's probably more important to make sure that you handle your co-workers safely as well. And just as I think maybe a bit of reassurance around the role of the specimens themselves, as far as we know, no confirmed laboratory-acquired infection has been reported for SARS-CoV-2 as a result of working with a specimen. Now, it's obviously very difficult to differentiate or to find out if a laboratory worker acquired COVID as a result of working with samples as opposed to working with a colleague who is infected. But as I said, to the best of our knowledge, no laboratory worker has contracted COVID as a result of working with the clinical specimens. And the same applies to MERS, the MERS-related coronavirus. And in the SARS-CoV-1 outbreak in 2003-2004, the only documented cases of laboratory-acquired infections were in people who were actually doing viral propagation, so trying to culture the virus where you've got large amounts of virus being worked with. And I think that gives us a little bit of reassurance that the process of working with the specimens, if you do it properly, reduces your risk of contracting the virus from the specimens quite substantially, and possibly to even zero. So if we look at our laboratory processes and potentially where the risks might be and what we can do to manage these risks, I think everyone who works in a diagnostic laboratory is familiar with the sort of division into pre-analytic, analytic, and post-analytic processes. And amongst each of these, you would then look at potential activities that may be a risk for exposure to SARS-CoV-2. So in pre-analytic areas, it's primarily specimen collection and transport. The analytic process is where most of the manipulation of the specimen happens, and one then needs to do risk assessment of both the staff and the procedures, which staff are at higher risk of potentially getting infection, but maybe more importantly, which staff are at high risk of developing severe disease. And I mean, the risk factors for severe COVID have been quite well described in terms of patients with obesity, diabetes, hypertension, underlying comorbidities, and so on. And then you look at your work environment, your PPE, your cleaning practices as ways of reducing the risk of transmission of COVID. And then I've put post-analytic and then sort of added other to this group, because the post-analytic is really the process of distributing the result and also obviously the waste disposal, which would be an area where one needs to look at practices and how risks can be mitigated. But the other practices one needs to look at in the laboratory are really around staff workflow, how they share teas and lunch times, how they handle non-analytical equipment. And that's not so much post-analytic, that's sort of a more umbrella term that kind of covers activities from pre to analytic to post-analytic as a collective. So if we look at the pre-analytic considerations in a bit more detail, these are mainly administrative measures that one needs to put in place to make sure that specimens are transported appropriately, using the UN 3373 regulations. Certainly in our setting, we've recommending that samples are not sent in a pneumatic tube because of the potential risk of breakage of specimens through the pneumatic tubes. And I think this depends on the environment you're working in. And when samples arrive in the laboratory, they need to be sorted and registered with appropriate IPC precautions. And I'll talk to these in a bit more detail later, but it's standard precautions that you do with any specimen that is potentially infectious. Maybe the one key consideration in your pre-analytic discussion would be if your laboratory staff are involved in specimen collection, then you need to have very robust protocols around this. So it needs to be done in a well-ventilated space, away from other staff members and other patients. And the laboratory staff need to have appropriate PPE in the setting, and this would be an N95 or equivalent mask, eye protection, gloves, and some sort of gown or apron as well. And we'll talk about the masks and gloves in a bit more detail later. Analytically, what I've tried to do here is just break, and I think one needs to then look at the different specimen types and look at the risk of transmission from a particular specimen based on the type of specimen and what's being done to it. So respiratory samples are clearly going to be the highest risk samples because the SARS-CoV-2 is primarily a respiratory disease, although there's a lot of evidence coming out that it is becoming more and more of a multi-system disease. But the virus is primarily found in respiratory specimens, and any work with an untreated respiratory sample should be taking place in a biosafety cabinet. And again, this is what you should be doing for any respiratory sample, whether it's the patient's got suspected COVID or not. TB is rife in Africa, unfortunately, and any respiratory sample carries the risk of having mycobacterium tuberculosis in it as well as a range of other respiratory pathogens. So any respiratory sample needs to be managed in a Class 2 biosafety cabinet, and staff members should be wearing appropriate PPE, which we'll talk about just now. And then for the other specimens, I think it depends on what's being done to that specimen, and this is where there's probably some debate and room for discussion. What we've been advising is that certainly tissue samples, if fresh tissue samples are being crushed and processed, that should be done in a biosafety cabinet as well. We generally try and crush our samples using something like a pestle and mortar. There is the risk of generating aerosols in that setting, so a biosafety cabinet would be appropriate. If you're working with formalin fixed tissue, the biosafety cabinet would be less critical. Stool samples, there's also some debate, and I haven't seen any clear guidance one way or another for this, to be honest. What we have advised is that if you are processing a stool sample where you like to aerosolize liquid or semi-formed stool, work in a Class 2 in a biosafety cabinet as well. And that's primarily based on the finding that you can shed the virus in feces. Whether this plays a significant role in transmission is unclear at the moment, but certainly there have been some calls for at least awareness of the fact that stool samples may carry viral virus and serve as a source of transmission. So be aware of how sewage is disposed of as well. Flush toilets with the lid down to reduce aerosolizing after flushing toilets. And using that principle, it would make sense that if you are working with a stool sample, particularly if there's going to be aerosol generation as a result of that, work in a biosafety cabinet. But for other specimens, certainly serum samples, other fluids, urines, standard precautions as you would for any potentially infectious substance in the laboratory would apply. And the COVID testing works, so using, so if you're doing non-propagative diagnostic laboratory work, which is really the PCR amplification for detecting COVID, that gets happening using biosafety level 2 procedures. Samples get processed in biosafety cabinets with an N95 mask, or the staff member wearing N95 mask and gloves. Bear in mind that the RNA extraction buffers generally render the virus non-infectious. So once the initial processing and RNA extraction has been done, the sample should be non-infectious and can be worked with on a general bench. As I mentioned earlier, propagative work, if you're trying to grow the virus in tissue culture, you do generate large amounts of infectious virus, and that sort of work must be done in a biosafety level 3 environment. But it's not applicable to routine diagnostic laboratories, and I'm not really going to touch on this or talk about this in any more detail. But just to be aware, if your laboratory is trying to culture the virus, you need a different level of biosafety as opposed to if you are doing nucleic acid amplification assays. And this is specifically for samples where you're processing the sample to detect the presence of SARS-CoV-2. For other samples where it's not based on SARS-CoV-2 testing, it's really the laboratory practices that follow good microbiological practices should be followed. And again, it reinforces the principle that any sample that comes to a diagnostic laboratory should be regarded as potentially infectious and follow standard guidelines for processing infectious material, regardless of whether the patient's known to have COVID or not, and regardless of what test is being requested on that sample. So this applies to from full blood counts, using E's, pus swabs, blood cultures, and so on. And finally, in the post-analytical phase, I mean, probably the main issues to talk about here are waste disposal. And again, waste needs to be disposed of as potentially infectious clinical waste, as you would for any other biological sample, and handled in accordance with your local regulations. So generally, or preferably a clearly demarcated container with usually a red lining, red bin liner. The gloves, the surgical masks and so on that you're wearing in your laboratory should also be regarded as potentially infectious and discarded likewise. Sharps get discarded in appropriate sharps containers, and then disinfectants to disinfect the work areas. And we'll talk about disinfection in a bit more detail just now. So there are a range of disinfectants that are available, but probably most commonly we use hypochlorite or alcohol-based disinfectants. So coming to the levels of control, and there's obviously overlap here. But when we talk about infection control for prevention of transmission, people generally divide them into administrative, engineering, and PPE levels of control. And I think particularly for those of you familiar with TB infection control, this is the classic triad of control measures. And administrative, a lot of the focus will be on staff management. And this talks to the fact that the risk of acquiring COVID in the laboratory setting is far more related to how you work with your co-workers than how you work with your specimens. So the administrative measures you might want to put into place in your laboratory would be things like team segregation and social distancing. When we first adapted our laboratory workflow when COVID started emerging in Cape Town and in South Africa, we divided our technologists into 4 sort of pods, if you like, and each pod was in a different area of the laboratory, and you wouldn't share staff members amongst different pods, so that if one person in that pod became ill, the other members of the pod were still relatively safe because the contact would have been minimized. We staggered tea times, the different pods went to the tea room at different times. You can try and stagger arrival and departure times. That becomes more complicated because you're at the mercy of public transport, and your laboratory workflow is also often dependent on people being on time. But all of this is, I think, tries to ensure that your laboratory can carry on offering a service even if members of staff do become ill. And we've had staff members in our laboratory who were infected with SARS-CoV-2 and had to go off work for sort of 10 days to 2 weeks. Fortunately, all of the staff members in our laboratory had a good response and came back to work. But anyone who's been working with that staff member also needs to go off and be in quarantine for 10 days to 2 weeks based on your local guidelines. So it can be very disruptive to laboratory workflow. What's also important is, I think, awareness among staff and have symptom screening programs. This is useful if people are symptomatic, but it's very important to remember that a substantial proportion of patients who acquire SARS-CoV-2 will have minimal to no symptoms. So the symptom screening is useful, but it's not the final word in trying to identify who's got SARS-CoV-2. And then using remote platforms for meetings and training and so on, just to try and reduce contact between different categories of staff or different staff members. Hand hygiene, I don't think I need to say too much to an infection control group around the importance of hand hygiene, and certainly I think one of the sort of silver linings in the dark COVID cloud has been the massive emphasis on hand hygiene and everyone's awareness of the importance of hand hygiene. But obviously that's an important aspect to reinforce amongst the laboratory staff, that hand hygiene is important. Cleaning surfaces, also an important part of general laboratory practice, whether or not you've got COVID around or not. And I think we've become more aware of the importance of cleanliness as a risk reduction strategy. So premises and surfaces need to be thoroughly cleaned and disinfected. One needs to focus on frequently touched areas and things like door handles, cupboard doors, light switches, bench surfaces, and so on. We recommend cleaning and disinfecting at least twice daily. This is difficult to put into practice, to be honest, because it can become quite disruptive. But what we try and do is, when people get to work, the first thing they do is clean and disinfect their work surfaces, and then before they leave, clean and disinfect the work surfaces as well. Less highly touched areas, floors and windows and so on, don't need to receive as much attention, but they do need to be cleaned as per your sort of standard protocols. And the disinfectants commonly used in the laboratory are really sodium hypochlorite or ethanol, as indicated there. But it's important, again, cleaning with a neutral detergent and then disinfecting afterwards. And as far as possible, ensure that your cleaning is documented so that you know that surfaces, walls, floors, etc. have been cleaned, and that the process is monitored and someone is making sure that it does actually happen. A few words about fogging and ultraviolet lights, and this is, I think, also sometimes contentious. When we had our first episode of a staff member who came down with COVID in our laboratory, there was a huge push for the entire laboratory to be fogged and commercially cleaned and disinfected at quite astronomical expense. The lab needs to be emptied for a few hours while this happens. And I'm not aware of any good evidence that these sort of fogging systems offer any substantial value over and above good cleaning and disinfection practices that should be happening regularly. What you may want to do is, if you do have a staff member who does develop COVID in a particular area, go in and do additional manual cleaning and disinfection of the area. But I'm not convinced that fogging is necessary. But I think it will depend on your own circumstances. But if you are fogging, just be aware of some of the limitations, that it's very disruptive to workflow. And I'm not aware of any good evidence that it adds a lot of value. And I would say the same thing about ultraviolet light. So ultraviolet germicidal irradiation is certainly practiced in many parts of the world as part of TB infection control. And I think there are moves to sort of evaluate its value in preventing COVID in healthcare settings and laboratory settings. Some limitations are, if you want to use it to disinfect surfaces, you need good line of sight between the light and the surface. And if you want to use it to sort of clean the air, you've got to have good air circulation so that all the air is moving past the ultraviolet light. Ultraviolet lights are often expensive both to install and to maintain. And we know from TB experience that maintenance of ultraviolet lights is often a problem. And after a few months, they lose their potency and you get a nice blue light that actually does not much. So if you are going to install and use ultraviolet irradiation as an infection control measure for COVID or other pathogens in your laboratory, just be aware of the limitations. And again, certainly in the context of COVID, I'm not aware of any additional benefit of the ultraviolet lights in reducing transmission of COVID in a laboratory setting over and above the physical distancing and the cleaning protocols that we're talking about. Spills and lab accidents, this is not COVID specific. This is something that should be happening. I mean, if you have a spill in the laboratory accident, you need to report it. You need to keep people away from the area so they don't go blundering through the spilt material. And you need to contain and decontaminate the spill area. And all laboratory labs should have spill kits that are available to manage spills, both in terms of having appropriate sort of absorbent material to mop up the spill and appropriate disinfectants to disinfect the area before it gets cleaned off and re-disinfected. Mobile phones become a bit of a discussion point locally, and I think it might be interesting to hear other people's experience about this. We've been battling for a while, even before COVID, to make sure that people don't use their phones in the laboratory setting at all, because it's bad laboratory practice. But COVID gave us a chance to actually try and reinforce that. And we know that a lot of inanimate objects can be the sources of contact transmission. The phones are used frequently and get passed from person to person. And then really our options in terms of enforcing cell phone discipline we're to either recommend that you leave a phone in the locker and you only go and use it once you're off work. If you decontaminate your hands, go to the locker and use your phone to do whatever you need to do. Or to actually put your phone into a Ziploc bag. So wipe the surface of the phone with a damp wipe, put it into a Ziploc bag, and then disinfect the surface of the Ziploc bag and use the phone while it's in the Ziploc bag. This is a bit more tricky to do and it's probably not that pragmatic. And I think it is important to remember that a lot of inanimate objects can serve as phone mites for transmission of COVID. Mobile phones are a clear example, and you need to have some practice in place to try and reduce the risk of transmission through shared phones. And shared computers are another challenge. In our laboratory, we've got a few computers in the laboratory area itself, which are used for entry of results, and they get shared by different people. So it's important to reinforce hand hygiene before and after using the keyboards and other peripherals. People shouldn't be wearing gloves when they are working on the computers, partly because cleaning your hands when you're wearing gloves is not really advised and not that effective. If you cannot enforce the sort of no gloves policy, then what you may want to do is actually designate certain computers as gloves only, so that people are aware that this computer is actually probably a high-risk computer, and other computers is no gloves allowed. And this depends again on your circumstances and how easy it is to differentiate those computers. And then otherwise, just keep your computers clean, so get rid of the physical dust, either by shaking it or using a brush. You can wipe the keyboards and mice with ethanol, which doesn't seem to affect the mouse or the keyboard. But don't pour ethanol onto your keyboard. That isn't a good idea, but if you get a disinfectant wipe, you can clean your keyboards and mice with wipes. Or you can use keyboard and mouse covers for devices which are easier to clean. And that's a lot of that is administrative processes. The engineering controls to prevent COVID, really biosafety cabinets are the most important, and that's not COVID specific. It's for any reduction of transmission of any respiratory pathogen from a respiratory sample. And I'm not going to go through the details of how one uses a biosafety cabinet, but it is important to make sure that staff are aware of the various protocols of what to do when you start using the biosafety cabinet, how you should be using the biosafety cabinet, minimizing disruption to airflow in and around the cabinet, making sure that you've got everything ready in place before you use the cabinet. If you're moving out of the cabinet, do so slowly, move back into the cabinet slowly to minimize disrupting the airflow, and disinfect the cabinet before and after use. And then obviously make sure it's maintained, and do your smoke tests and your servicing and so on. So the biosafety cabinets, in terms of engineering controls for COVID, is one of the key ones. And given that the respiratory sample should be worked with in a biosafety cabinet, it's important to make sure that your cabinets are functional and that staff are aware of how to use the cabinets. And then other engineering controls related to COVID, and these are things that we've started to implement in our laboratory. Ideally working in large, well-ventilated rooms, although that's very difficult to do if your lab space is already fixed. So it's a lovely theory, but it's very difficult to put into practice when you're working in an environment that's established. But if you can look at ways of redistributing staff and having fewer people working in closed rooms if possible. Open your windows, particularly in offices. Open the windows to improve ventilation, and in meeting rooms and so on. In laboratories themselves, this is probably not always possible because of safety concerns around having things in the laboratory float into the air. But try and look at improving ventilation in the laboratory, reducing staff. What we've started doing is putting perspex shields between benches where the benches cannot be separated. If you've got staff working on two sides of a laboratory workbench, put a perspex shield between them just to reduce the risk of transmission from one to the other, and adjust your workflow. And finally, PPE, which is generally seen as the last leg of the sort of controls for reducing nosocomial transmission of pathogens. I think it's the first thing people get excited about when they're looking at laboratory safety. It should actually be the final step of your safety journey rather than the first step. And again, with COVID, everyone's become a self-proclaimed expert on masks. So I'm not going to go into masks in massive detail, but obviously we need to be aware that the N95 respirators or equivalent really should be only worn in specific circumstances. So if you're doing aerosol generating procedures, so if you're either collecting a sample from a patient or you're working with COVID-containing samples in a biosafety cabinet, then an N95 respirator would be appropriate, but otherwise reserve them for the people who need them. Surgical and medical masks, in our setting, we're using these for all staff in the laboratory, particularly if they're working in proximity to others. So if I'm alone in my office, I don't wear the mask, but if I'm going into the laboratory or having a meeting, then I will wear a surgical mask. And our recommendation locally is to wear them for about 4 to 6 hours and dispose of them appropriately in the waste disposal. And at the moment, there are no reliable methods to decontaminate and reprocess your masks. So we're not recommending reprocessing of surgical masks. And I think even the N95 respirators, the reprocessing is quite a contentious issue. There are some studies being done to look at ways of reprocessing N95 masks. But if you do that, make sure the method you're using doesn't damage the integrity of the mask and renders it fit for use. And then other forms of face mask, face shields, the plastic shields to wear over your face can also reduce droplet exposure. And particularly for people who wear glasses like myself, where they get fogged up as soon as you put a mask on, face shields are an alternative. Or if you've got limited supply of surgical masks. And then cloth masks are recommended certainly to reduce community transmission outside of the workplace. And if you've got a limited supply of surgical masks, cloth masks in the workplace are also absolutely fine. So, and again, and this is primarily to try and reduce transmission from person to person in the workplace. So a cloth mask or a surgical mask in the workplace, if you're not working with COVID samples, is fine. When you're working with the COVID samples, use an N95 respirator. And then obviously wear gloves when you're handling specimens, which should be part of standard practice as well. And if people are wearing gloves and masks, just reinforce the sort of appropriate order for donning and doffing of PPE, which gets quite confusing. And discard your PPE in appropriate disposal process when you're finished with it and regard it as potentially infectious material. If you've got non-single-use PPE, and this would really be sort of the heavy-duty gloves that cleaners may be using, the domestic gloves, you can decontaminate them using either sodium hypochlorite or ethanol, but make sure that whatever you're decontaminating is suitable for use with those particular disinfectants. We know that sodium hypochlorite can damage materials with repeated and prolonged exposure. So ensure that if you are decontaminating non-single-use items, that they can be decontaminated using a particular disinfectant. So I think I'm just coming to the end of my time, so hopefully good timing. I think the key points from this, to re-emphasize, if we look at COVID specifically, the risk of contracting COVID from a lab sample is far less than the risk of contracting COVID from your colleague in the workplace or colleagues in society. So lift sharing and things like that are also high-risk activities. It's important to maintain standard laboratory safety practices, and something we always try and teach is regard every sample as potentially infectious, and COVID gives us a great opportunity to just reinforce that message and really pay extra attention to social distancing, masks, and high-end hygiene in the laboratory setting. And your COVID-specific practices around dealing with respiratory samples should actually be limited to a small number of staff and a relatively small number of specimens. And I've put up some guidelines here from the WHO, CDC, PHE, and so on for if people want to get more information, and as well as general links to ICANN, Africa CDC, and so on for additional information for anyone who wants to get more information. And I think one of the things we do need to remember is a quote from Professor Shabir Mahdi, who in the webinar a couple of months ago said that there's no such thing as a COVID expert. I think we're all learning as we go along, and it's important to remember that things change. So it's helpful to keep up to date with the latest recommendations. And finally, I'd just like to thank colleagues who certainly contributed to our local discussions around laboratory IPC related to COVID. So Prof. Preiser from our virology department, Adrian Brink, Angela Dromowski, and Shaheen Mehta, which who I think is familiar to everyone on this call. Thank you very much. And I'll stop sharing.
Thank you very much, Prof. Whitehall. We really appreciate this. I can just tell everybody we will allow for questions and answers at the end. I would just like to introduce Dr. Munir Morris Togo from South Sudan Public Health. That's going to give us a country perspective on South Sudan. Welcome, Dr. Munir. Over. Do you want me to share your screen with your presentation? Dr. Munir, are you on? Can I please just Prof. Shadai, you're talking. I don't seem to see.
Hello.
Oh, I don't see Dr. Toko on the line. I just want to make sure that he is on. I've got Dr. Morris on. Can you hear me, Shadai?
I can hear you now.
Okay. I'm just trying to find out. I don't see him to be on the call.
Who is that?
Dr. Toko from South Sudan. I've
Uh-oh.
got this on. Hi.
Is anybody representing Dr.
Morris, you are welcome. He's on the call now.
Oh,
Just
okay,
unmute
great.
yourself, please.
And kindly unmute your microphone, please. Dr. Morris, can you hear me? Kindly unmute your microphone. We cannot hear you.
Hello, hello.
Okay.
Yes. Well,
Go ahead, please.
Thank you.
do you want me to share your presentation, or would you share from that side?
Yeah, I'm sharing from my side here. You can share with those who are with you there.
All right, I'll do that. Thank you.
Yeah.
Can you all see my screen?
Yes.
All right.
I'm
You can
sharing.
just tell me, and then I can move on for you.
No, I'm sharing my own here.
Okay, that's good. Then I'll stop mine. Okay.
Yeah. Yeah.
That's the thing.
Yes. I'm Dr. Munir Morris from South Sudan. Yeah.
Well,
so I have to give you the COVID information. Right to where we have to go to statistics on COVID. The date of first case in South Sudan was the 5th April 2020.
Dr. Morris.
Your screen is not up.
My screen is not off.
No, we can't. We can see you, but we can't see your screen.
just look at the bottom and just open up your presentation, and then just say share screen.
Are you seeing me now? Still, you're not seeing it?
Not yet.
Still, you're not seeing me?
We can see you, but not your screen.
When you do share screen, then you should tap. You'll see your screen on the corner. You need to tap.
Okay. You share the screen so that I follow you.
All right, quickly, let me share my screen.
Yes, I have to see your screen.
Okay, can you see my screen now? Your presentation?
Yes, Zoom.
All right. I'm just going to go from the current. So can you see this now?
I'm seeing Zoom during a meeting.
Okay, you don't see your presentation. Can anybody else see the presentation?
Yes, we can see the presentation. Maybe Dr. Morris, since you have yours on the screen, use yours, and she'll be changing the one we can all see. Is that all right? We can see it.
Now you are seeing my screen now?
Not your own screen. Okay, country information. We can see that.
Yeah. Is it your screen?
No, it is our screen. So you go on and just be saying change whenever you want to change. Yeah.
Okay. Country information. Here now you can see the map of South Sudan. The population is 8 million. The states, we have 10 states and 3 administrative areas. The healthcare facility that has been evaluated on the IPC tools is 256. Move. Go on. Yeah. COVID information. Date of first case in South Sudan was on 5th of April 2020. Number of cases 2,494. Number of active cases 1,157. Number of deaths 47. Number of healthcare workers infected 115. No discharge. Number of discharge is 1,290. Average age patients is 50.1. Go ahead.
Okay.
Case scenario. My scenario is a live scenario. The burial team was assigned to go and collect sample from a dead person. After they collected the sample and taken to the lab, the team lead was asked to report the list of the contacts. He replied that register of the contacts list is the assignment to be conducted by the RRT, not the burial team. Thereafter, the motion was raised in the meeting regarding this live case scenario. My question goes back to you. Who's to register the contact list? Go ahead.
Okay.
IPG challenges. Knowledge on wear a mask was high, but the attitude and actual practice observed did not align with respondent knowledge. Low uptake on used cloth face mask among population. Low adherence to IPC measures in health facilities, less than 50%. Of 1,315 IDSR targeted health facilities supported have received IPC and PPE supplies and training to enhance IPC measures against COVID-19. Similarly, IPC measures such as physical distancing is affected training organizations and supervision. More IPC supplies on the job practices training and supportive supervisions are recommended to boost IPC measures at health facilities. To date, only $20.7 million or 43% of the total IPC response requirement has been funded. Most of partners are running out of funding by August to September. Yes, go ahead. Solutions. There is a need for IPC structure to be put in place at the health facilities level. 8 components of IPC must be in place. There is a need for more additional efforts to influence attitude and increase proper practice. Messaging needs to change to increase risk perceptions of population to focus on the symptomatic nature of COVID-19. Risk communication matters a lot here. There is a need to advocate for supporting and funding the administration control, engineering control, and environmental control. There is a need to engage CBOs leaders in awareness raising for passing the IPC messages deep into their various localities. Move ahead.
Okay.
Lesson learned. How to prevent. Performing hand hygiene frequently with an alcohol-based hand rubs if your hands are not visibly dirty, or with soap and water if hands are dirty. Avoiding touching your eyes, nose, and mouth. Practicing respiratory hygiene by coughing or sneezing into a bent elbow or tissue and then immediately disposing of the tissue. Wearing a medical mask If you have respiratory symptoms, performing hand hygiene after disposing of the mask. Maintaining social distance, 1 meter at least, from persons with respiratory symptoms. How to recognize, for good recognition, ensure triage and sources of control. How to solve the problem quicker or better. You have to make sure that you have your trained hierarchy in place with the ambulance aside for any calls. Go ahead.
Okay.
Ongoing gaps. The gaps we have here, we are lacking enough PPE supplies, especially at the state level for the healthcare workers. We are lacking enough IPC training, especially at the health facility level. There is not enough training and awareness towards communities, such community leaders, church leaders, civil society organizations. Lack of hand washing stations at the public places, such as markets, schools, worship places. Ignorance in use of personal protective equipment by the healthcare providers. Lack of enough funds to address the above mentioned gaps. Move ahead.
Good.
Thank you for all those who have shared these good information with us. This is Dr. Morris from South Sudan.
Thank you, Doctor. Wanda, over to you.
Okay, thank you so much, and thank you very much, Professor Andrew, Dr. Idowu, and Dr. Morris. We will go to the Q&A section now. On my panel today, I have Professor Shade, Professor Andrew from ICANN, and Anna from ICANN. We also have Africa CDC experts on the call, and also Karen from Resolve to Save Lives. So I think our question, my first question is, with respect to face shield, one of the presenters said it's an alternative where there's shortage of surgical masks for those who wear glasses. But face shield alone is not protective without face mask. Please comment. Professor Shade, if you would like to take that question, please.
Thank you very much. Let me say, the value of face shield is to prevent splashes to the face. Situation, for example, not in a room where you have ventilation issues and you, because we're talking about the lab, where you're dealing with samples, and your greatest risk, if you remember, is from something splashing into your face rather than, or from your colleagues. So if in that case, the face shield could help. But as a standard practice, a mask is, with a face shield is a better option because it actually protects your respiratory tract. But where you're not close to people, where you are not within, when you're not in a situation where you're having air being circulated, a face shield can be protective, can be adequate. Let me use that word. But if you're in a situation of close contact, where you're in a situation of circulating air, then you must have a mask. Thank you.
Fantastic. Thank you so much for that. Professor Andrew, if you'd like to take this, this just wants a difference between the N95s and the KN95s. I'm also going to welcome comments from other colleagues on the call regarding the difference between N95 and the KN95.
So I must say, I'm not aware of the KN95, so I'd be interested to hear if anyone else has got any comments around the KN95 and what the differences might be. I'm only aware of the N95 masks, so I'm going to bounce the question back to somebody else.
Okay, fantastic. Thank you. Anna or Prof. Shade, would you like to take a go at
okay, the KN95 is actually from China, and technically it should be the same specifications to the N95. So they're similar. It's just that KN95 is from China. The only problems we have with the KN95 is that where they've been evaluated, there have been differences in their efficacy depending on the manufacturer. So that's really sometimes the problem with KN95. But where you're getting it for a good manufacturer, it's essentially similar to the N95. Thank you. But it's made in China, is the Chinese equivalent.
Thank you very much. So that is fine. I have a question for Dr. Morris. It's just a comment around comparing country perspective. This person says, compared to the statistics from Nigeria, the average age is 50 years old. I would like to know the probable reasons for having predominance infection in this age group. So I think Dr. Morris, if you would like to talk about the age distribution as seen in South Sudan, maybe our participants is able to learn from that. Thank you.
Yes, thank you for the question. Geographically, the people live in South Sudan, they vary from place to another, and even the lifestyle varies according to where they are staying, because we do have Nilotics. They depend on their cattle, cows, and all this. And we have those who are just cultivating their crops around. And generally, those who live longer, it depends to the way they prevent themselves from the diseases. But most of I can say 80 to 90% of the food we are eating in South Sudan is just a natural food. Only some food we are receiving from outside of the country. I can say 70 to 90% are mostly artificial foods, and this reflects back to decrease the life age of people in South Sudan. But back to 70s and 60s, the average of the ages is more than 70 in South Sudan. But now it's decreasing due to the changing of the lifestyles. Most of the food is now tend to be artificial kind of foods, and this can reflect back to the health and especially the organs inside our bodies. So that's why our age is now decreasing even in South Sudan. From late 50s to 70s, the death cases really happen. If not death, even people are suffering from diseases, especially underlying diseases. This is what I can add.
Thank you so much, Dr. Morris, for that very insightful comment. I see that colleagues are also putting some of their questions on the chat box. We encourage you to put your questions on the Q&A function so that we're able to address some of your questions. We're live streaming, so in a couple of minutes, I'll also check if we've got questions from the Facebook live stream. So Karen, I don't know if you're happy to answer this question. It's just really on the concentration of chlorine for the contamination of PPEs and surfaces. The question is, must it be 0.5% chlorine or must it be 0.1%? Over to you, Karen.
Thank you. For small surfaces and face shields, etc., should be 0.1%. 0.5% is for blood and body fluid spills. That's the strongest that's used. And WHO changed its recommendations sometime in June, limiting that strength of chlorine dilution just to blood and body fluid. Thanks.
Thank you very much, Karen. I see that that is also on our call on the Q&A. Somebody was asking about the concentration. So just to reiterate, for blood and body fluid spills, we encourage, in line with our guidance at Africa CDC and at WHO, 0.5% chlorine. So this question is targeted to you, Professor Shade, has your name on it. It says, please, can you clarify between circulating versus non-circulating air? I tried to apply it to what you said, and it's not clear. So, Prof. Shade, if you want to just discuss that a bit.
Okay, let me, first of all, what we want in terms of air is about air exchanges. So you want fresh air constantly coming into a room. So big open windows would not constitute circulating air. But if you had your windows closed and you had air conditioners, usual room air conditioners, the air will be flowing within, because it extracts air and takes it, it turns it round. Then that is circulating air. It's not escaping. You're not having fresh air coming in. So anywhere where you do not have constant fresh air going in and out, that's a dangerous area. The other area would be, even if you had a room where you had some windows open and you had lots of people there, then the airflow in terms of air coming in and going out would also be affected, and you can have droplets staying in the air for longer than you would normally want it because of the sheer volume of people in that room. So what you really want is to constantly dilute the droplet coming out of people's mouths and noses. So air conditioning, which is what we all use, it's generally dangerous. When I use the word dangerous, is relatively riskier. Is riskier than if you had your windows wide open and fresh air is coming in and diluting and the droplets in the air. So that's what I mean by circulating air. So if you are in a room where you have your air conditioner on, then you must wear the mask. But we advise that where you are with people, please wear a mask. There are people there. If you're walking on the streets and it's not in a crowd and you're not moving close to people and you have a face shield on, you're fine.
Okay.
If I may add to that, sorry. I think I talk about the 4 C's, close contact, close spaces, close contact, close spaces. It's gone off my head now. And the 4th one is continuous exposure. The 3 C's, pardon me, it will get back to me. It just left my head. Anyway, that's
okay. Okay, fantastic. Thank you. So I think I will just dive into the Facebook Live questions. Dr. Morris, you have a question. It's directed to you. Is there any data on the incidence of COVID-19 case amongst the burial teams for South Sudan?
Up to now, no. Any case of death among the burial team, because as IPC, we used to make sure that all the procedures we are putting in place so that for them to manage to use appropriate way of how to use their PPEs and how to handle the situation on the ground while they're doing their job.
Fantastic. Thank you, colleagues on Facebook. Please keep your questions coming. Did you want to say something?
Yes, you don't have to remember, I raised the question in my live scenario. So up to now, no answer.
So if you would like to put just summarize that question again, then we can have a brief panel take at that question.
It was just a simple question. Whose work is that to collect the contact list? Is it the work of the burial team or the work of the RRT?
So I think I can have a first go at that. Then my colleague Mohammed on the call might also, it's totally dependent on your incident management team and what your structure is. For the contact tracing, ideally should be your surveillance teams doing the follow-up and things like that. So it totally depends on the country or the subnational incident management teams. So it's not something that is prescriptive. It's totally depend on your capacity and the workforce. Or we as Africa CDC, we are supporting supporting countries to have contact tracers through community health workers to support the contact tracing. So ideally, those people would feed the information back to the surveillance team in each incident management system. So I think that's a good answer to that question. Mohammed, I don't know if you have any additional things to add on. Okay, that's fine then. I think we can go to the
Yeah, may I just say a word?
Okay, sure.
Yes, I think exactly what you said is true, but I feel that if the burial team gets there and they can get the information about the people, which they can pass on to the RRT, I don't see why they cannot get some information to share, because sometimes you're in situations where people are stretched. So if there are people on ground and you can get some information, even if it's just about the close contacts at that time, it would be helpful to whichever group of people. I think as we share the work, it's really to have those guidelines, but it's not such that it's not your exact schedule and you're the only one available to do something. I think if you get some information as to close contacts and pass this on, it could be helpful. But sometimes these are the things that cause the gaps that we have.
Okay, thank you very much for that additional input. I think we're all learning through this pandemic to sort of double up on our roles. So I think that's a very helpful comment. Prof. Andrew, this question, which has come in like a couple of times, says that, can you please tell us a bit more around fogging? I think you must have mentioned it in your slides and our participants want to learn a bit more about that.
Yeah, so I'm not quite sure what a bit more means, but so maybe just to reiterate what I said earlier, or maybe start a step back. I mean, the process of fogging is essentially taking a disinfectant and aerosolizing it in a setting, usually a room or a business premises or something like that, and allowing that to both disinfect the air, but also, I think more importantly, settle onto surfaces and disinfect the surfaces, and seen as an easier and a more efficient way of reaching all the surfaces in a room. It would normally be, I think the commonest disinfectant they use for fogging is hydrogen peroxide, but you could do it with other disinfectants as well. As I said earlier, the problems with fogging are, there's not a lot of evidence that it's any better than manual deep cleaning. There is debate as to how well fogging actually cleans an area compared to elbow grease, if I can put it that way. And if I'm correct, I think the WHO and CDC have actually recommended that fogging shouldn't be used to clean or disinfect work areas, and that they recommend sort of manual cleaning with a disinfectant rather than using fogging. So there are still a lot of companies that are trying to sell their services as using aerosolized disinfectants or fogging, but it's unlikely to offer any significant benefit over traditional manual ways of cleaning surfaces and disinfecting your workplace. I'm not sure that answers the question, but that's what I would say.
Great, thank you so much. Anna, if you'd like to take this question, this has come from our participants on Facebook Live, just asking about the duration and the limited use of N95s.
Thank you, Wande. What we normally would say is that the N95, they could use it for a 12-hour shift or for up to a week. What we normally suggest is that they do store it properly in a container. At the moment with the COVID, they are saying to let it hang and have it air dry, air circulated around it. As long as the masks are marked with the person's name, they can wear it for a whole week. And then also to perform hand hygiene and also checking how you put it on and how you take it off. It's really important that they don't contaminate their hands with the front of the mask as well. And when they remove it as well, how to take it off. So it's important to look at the donning and doffing. And that's what we would suggest for the N95. Thank you. Over.
Thank you very much for that, Dr. Morris. Another question to you. Your slides were particularly fantastic. So I think it's important that we have this platform for country-to-country learning. This question is that South Sudan prescribed social distancing of 1 meter apart from for persons who are subject of respiratory disease. Is social distancing applicable only to those who are suffering from respiratory illness? I think this participant just wants you to sort of unpack the social distancing measures already being done in South Sudan, looking at how sometimes we have asymptomatic COVID-19 patients and how your country is going about this. Over to you.
Thank you for this good question. Social distance, the risk communication is doing our best to give awareness about the importance of social distance. But up to now, to be frank with you, in South Sudan, application or the way the people are applying the social distance, I can say maybe 30 or 20%, because there is a belief that majority of the community they are challenging the health personnel or health providers that the COVID-19 is not real even to the extent even the educated class they're challenging the health professionals while they are giving messages and all this about issues with the prevention and control. But the social distance, if you visit our markets here in Konyo or Munike market or Nyakron market, you will wonder people are just squeezing themselves in one place. No more apply of social distance. To the extent some of the people they put their mask in their pockets while they're entering the markets. So, but still, never ever give up. We are trying our level best to give awareness to the community and for how to show them the importance of social distance and using of masks and others. Thank you.
Thank you so much, Dr. Morris, for that. I'm just going through the questions. Please keep your questions coming. Again to you, Dr. Morris, there's another question right there for you. Among your challenges, you said knowledge on wearing masks was high. However, attitude and practice did not align with the responders. So I think the question is, how are you able to measure the knowledge on the use of masks, and how long were you able to monitor their attitude and their practice?
Yes, we have some reasons contribute or attributed for this, to have a high knowledge and not to put it in action. Why? Because among those who are ignorant about the use of mask, while they are educated class, they say this mask even is not giving a way for you to breathe good. That's why they are feeling so they're not feeling good while breathing inside the mask. So that's why they dislike to use mask. Sometimes some group they say this culture of the whites, they are trying to change the style of living, and some are saying no, they are trying to poison this mask even to give us so that we can get the diseases and all this. So we are facing a lot of challenges with regards to those who have knowledge and they don't want to apply it, they don't want to use it.
Thank you so much, Dr. Morris. I think your response really unpacks a lot of things that we are facing around the world and across the continent is the challenge in terms of getting people to actually change their behaviors. Sometimes they know the usefulness of this mask, but there's the thing about human rights, discomfort. I just don't feel like doing it. So as health workers and as IPC experts, I think that's one of the big work that we have to do is, with that knowledge, helping to drive behavioral change. And that's why we need to all embrace a multi-sectorial approach of having anthropologists, behavioral scientists, and social scientists to help us understand what people don't really get about actually adhering to use of face mask. So I think this last question I will throw at Prof. Is I've seen people put on double or two surgical masks at the same time. Is this helpful in ensuring prevention? Prof, I know you would remember that we have had this question almost every week, and I think we need to keep talking about it. Over to you.
Thank you very much. I think it's an overkill. Certainly, what is most important for your mask when you have the surgical mask is that it's well fitting and you wear it properly, because the whole because studies have shown, many studies have shown in general that I don't want to say that there's no difference, because that's not really correct, but that the difference is not overly significant. I think what is most important is that it is covering your nose, your mouth, and your mouth and nose properly, and it's well fitted to your face. Wearing double, I don't think it adds much more value to your protection, and it's a waste of PPE.
Thank you very much for that. I'm just trying to make sure. Someone is saying, so I'm going to throw this question at Anna, saying, due to hypoxia, how long should one keep or wear a mask on the face? I think it would be nice for Anna and Karen to give a bit more answers to this. I think just going back to the issues around attitude and practice, I know that there have been a lot of myths circulated on the internet that it makes your breathing worse, you get brain damage and things like that. So I think we should address it so that we are able to take back, and we are also able to correct the notion that is being spread across the internet. Over to you, Anna and Karen.
Thank you, Wande. What we would normally say is it depends on what type of mask you're wearing. Also to look at the fabric it's been made of. Does it fit properly? And then normally people with lung problems, what we would suggest is that they, depends on only when they're outside between people, but when they're inside to remove it. And just to make sure that, they've got correct their breathing as well. But it definitely depends on the type of mask you are wearing. But it won't create hypoxia unless you've got a lung problem. But normally people with lung problems, we would advise them to stay away from crowds or to go out if need to be, and then just to see their doctors. But it's been tested, and it doesn't normally create hypoxia for anybody if you wear your mask a long time. It does feel uncomfortable, but it's just because we're not used to that. I don't know if Karen's got anything else, but that's just what we have found. It depends on the material that the mask is made of and how's it fitted around your face, and what you're doing while you're wearing the mask. But the idea is to wear the mask when you are you can't have the social distance and when you're out inside a crowd. But if you do have a comorbidity, to rather stay inside and keep your distance. Thank you. Karen.
Yes, I think you need to distinguish between medical masks and cloth masks. Neither one of them causes breathing problems in terms of permanently damaging your lungs or any of that. As Anna said, can be uncomfortable. Medical masks, particularly when it's quite hot, if you're wearing it for hours, it can be quite uncomfortable. The only recommendation I can make is to take a break, carefully remove it, perform hand hygiene, and let your face be exposed to the air outside of a highly infectious environment. Cloth masks, on the other hand, really should be made with comfort in mind, and it should not be an issue. And I think if you're out in the open and you're nowhere near other people, you don't need it. But if you're going to be near people, remember that it's protecting them from you as much as anything, so that in case you are asymptomatically infected, you will not transmit viral particles and droplets because you are wearing your cloth mask.
Yes, I totally agree with Karen. I was assuming they were talking about cloth masks, but even with the surgical mask, as Karen said, we need to look at, you know, how you're wearing it and where you are, and the idea that why you are wearing mask. Over.
Okay, thank you. I'll just take one last go at this question. Looking at the person is highlighting N95s, and while they're doing laboratory tests, I think I shared with you on the chat the Africa CDC PPE guidance, where we recommend medical or surgical masks. Ideally, we encourage that N95s or respirators be used for aerosol generating procedures. So yeah. I just wanted to also just highlight that, because I have a question on the chat box saying that they have run out of N95s, and please look on the website too. We also have a guidance around managing shortage of PPE and how to safely protect health workers. On that note, I say thank you very much for your fantastic questions. I will hand over to Anna to display the QR codes and to take us off for the session. Over to you, Anna.
Thank you, Wande. Yes, and thank you for everybody that have joined us. Just remember, we'll have the same slot next week to join us again on this next topic. And then on Friday, we have the French version going as well. Just for a reminder of the N code that you need to scan for your attestation. And remember, you have to download the app. If you're using your phone for this call, you have to actually download this, and then you have to print it or display it on your computer so that you can scan it. You won't be able to do it while you're on your phone. So this is available, and every week there's a different code, so you can't use the same codes every week. And then just thank you, everybody, and hope to see you again next time. Thank you very, very much, and have the rest of the day.
Thank you.
Thank you. Bye.
Bye.
And I just, for these on call, still just say, please go to the Telegram community of practice as well. All the links and the answers and some questions can also be placed there, and we will address it if it's possible, or direct you to where we can. Thank you.